Thank you for this short introduction. So indeed, my name is Dimitris Zopoulos. I'm a professor of biostatistics in the Department of Biostatistics of the Erasmus Medical Center in the Netherlands. And as Rok mentioned, I have been working for quite many years now in this area of joint models for longitudinal and time-to-event data. I have done also written some methodological work, but I have also written some software packages to apply these models in practice. And we have also used these models to answer interesting questions that we receive from our clinical colleagues, because as I said, I am located in a medical center. And this is actually also the topic of my talk for today. So we are going to see for a very practical question that comes often in clinic, how we can use some advanced statistical methods to try to answer it. Okay, so let me start by giving you a little bit of a background and the motivation of what is the clinical question that we are trying to address here. And to put you a little bit into context, the motivation from this work comes from our collaboration with the Department of Urology in the Erasmus Medical Center, and in particular the group that works on prostate cancer, which you may or you may not know, but is one of the most prevalent cancers for men worldwide. Now, because of this high prevalence, in many countries, there are screening programs where the idea is to find men with prostate cancer, with tumors in the prostate gland, and of course, and help these patients and give them treatment. But as it is the case also with other cancers, like, for example, also breast cancer, there is also the problem of what is called overtreatment. So what we mean by that is that many times patients receive treatment even though this may not be required. And in the particular case of prostate cancer, this is very, very relevant because the prostate cancer is a cancer which for the majority of the men involves, so grows very, very slowly. And therefore, there is a higher chance that these patients may die from other reasons and not for reasons related to the prostate cancer, so no metastasis, no things like that. So therefore, giving treatment to these patients is not advisable, it will not be good, because also this treatment many times is quite invasive, so it's like to remove the prostate gland, that leads to many side effects. So for that reason, when they find these men who have what they call typically low-grade tumors, instead of directly giving them treatment, what they instead do is that they advise these men to enroll active surveillance programs, where the idea in these active surveillance programs is that these men are going to be monitored more closely. So they are going to do some examinations to them and see if the tumor starts growing. And if the tumor starts growing, then is when they will give treatment. They will do this more invasive treatment like surgery. Now, how the progression of the cancer is monitored. So in prostate cancer, we have a very useful biomarker, blood biomarker, which is called the prostate-specific antigen. And typically, people who are in this active surveillance program, they will have this biomarker measured every 6 months. They are also coming for what is called the digital rectal examinations. This does not happen every 6 months, could be a year or 1.5 years and so on. And nowadays, people are also using MRI techniques, so to see if the tumor is growing. But yet again, because MRI is expensive, is not used that often yet. But really, the decision to give treatment to the patients is based on biopsies. Okay, so they are biopsying the prostate gland, and then to see if the tumor has increased in size and volume. And when they do this biopsy, they give a particular score, excuse me, a particular score to the tumor, which is called the Gleason score. And when this Gleason score takes a value which is above 7, then is when treatment, a more invasive treatment is advised. And just to say that all the people who entered in these active surveillance programs, they have a Gleason score of 6. Okay, so they enter the program with a 6. And then what the urologists want to find is when this Gleason will become a 7. And again, as I mentioned, just to briefly summarize, they do that with biopsies. Okay, so they're going to biopsy the patient. So therefore, a very relevant here question is how often should these patients receive a biopsy? And there are two dimensions that we could consider. So how many biopsies a patient will do in his lifetime, and what would potentially be the delay in finding progression so that the cancer has increased, if this indeed was the case. And as you can imagine, these two dimensions are inversely related to each other, because if I increase the number of biopsies that I'm going to do to a patient, then I'm going to decrease the delay, and the other way around. So if I'm going to do very few biopsies and spread them very in a wide time interval, then perhaps the delay is going to be quite long. So therefore, for the delay, we want to find the progression relatively as soon as possible. So even having up to 1 year delay in finding the cancer because of the low progression rate that I mentioned is considered clinically okay. But regarding the number of the biopsies, there is where the issue is and what motivates our work, because these biopsies are high burden. So they are painful, they can cause complications to the patients, and they are quite expensive. So therefore, in these active surveillance type of programs, there are kind of two major types of programs that are around in the world. So are the types of programs that really focus in minimizing the delay as much as possible, and they do annual biopsies. And there are also the programs that try to balance a little bit this, and they do a biopsy every 3 years, and they switch to an annual biopsy if they see that the PSA increased between the two successive visits. But the problem with both of these type of programs that are currently available for monitoring prostate cancer is that we do too many unnecessary biopsies, especially for patients who progress slow. And even for patients who, as I said, not only progress slow and therefore at some point they will require treatment, there is also a high percentage of the patients who will not require treatment at all. Okay, so as I mentioned, they will perhaps die from other reasons in old age and not die from their prostate cancer. So for these patients, therefore, we would have done many unnecessary biopsies, even though they never required treatment for their prostate cancer. And now, what is the practical problem of doing this many unnecessary biopsies is that these programs suffer from low compliance. So the patients can go for the first 2 rounds of biopsies, but because then there always comes negative, and because of the complications that I mentioned, they don't go back to do the biopsies as prescribed in the program. And as you can imagine, this greatly compromises the effectiveness of these active surveillance programs. So this is where our work comes into play, because we think that there is considerable room to improve this biopsy scheduling. And what is our approach and the new approach that we have proposed in our work is not to use the same scheduling for all the patients as it's now done. So either this 3-year schedule or the annual schedule, but really to try to personalize the scheduling using the information that we have available for these patients. And what is our very basic and intuitive idea is to personalize the scheduling using the individualized risk. Okay, so what is the risk that the cancer of this particular patient has progressed? And using this risk estimate to try and schedule biopsies in a more effective way. And to give you a little bit of motivation for that is that indeed that a nice reason why we would like to do that is that the progression rate is not only different between patients, but also changes over time for the same patient. I didn't say before, but the data that I'm going to show you now and a figure from comes from a very big cohort of active surveillance, which is called the PRIAS cohort. So this is an international consortium of people of patients of active surveillance around the world. And using the data from this cohort is the idea that we would like to develop this personalized approach. So using the data from this PRIAS cohort, we see that indeed on average, this is the PSA, this biomarker for the prostate cancer. And this is the follow-up time over years. So where 0 is when the patient was detected with having the cancer and he entered the active surveillance program, and this is the time during the active surveillance program. So what we see here that on average, this PSA is very stable if I'm going to average over all the patients. But if I look at individual patients, like here, I have a sample of 16 patients that I'm showing you. So you see quite some heterogeneity in their PSA trajectories. And this is the idea behind our approach, is to try to use this heterogeneity that exists between the patients and try to see how we should more effectively plan the biopsies for a specific patient and not just work with the average. And as I mentioned, so what our basic idea will be is to use risk predictions. Okay, so to use all the available information that we have, so the available PSA measurements, the available digital rectal examinations, and use also the time and results of the previous biopsy, so to derive a risk of progression, and then based on this risk, to schedule the next biopsies. Okay, so indeed, if I want to summarize it, so what is our new approach for better planning biopsies? So first of all, we would like to understand how these longitudinal measurements that I have for the PSA biomarker and the digital rectal examinations are related to the Gleason risk classification. So what is the Gleason risk classification is the time the Gleason score will become a 7, okay? So it's when the treatment is going to be given to the patient. So first of all, we would like to see how these outcomes are related to each other. Then to see how can I use these longitudinal PSA and DRE measurements to predict this classification, so to predict when the Gleason will become a 7. And then using that to see how can I plan the next biopsy for a particular patient. Okay, so how we are going to do that? As I said earlier, so we are going to use this framework of joint models for longitudinal and time to event data. And let me use this slide a little bit to motivate why we're using this type of models. So going back to the first question that we have here, okay, so what we want to do is that we want to take these longitudinal measurements and associate them to the Gleason, the time that the Gleason will become a 7, okay, so this Gleason risk classification. So therefore, what we actually want to do is that we have a survival outcome. So this is the time that the Gleason becomes a 7. And I have two longitudinal outcomes. I have the PSA measurements, which is a longitudinal continuous outcome. and I have the DRE measurement, which is a longitudinal binary outcome. So essentially what we see that I want to do is that I have two time varying covariates. So these two longitudinal outcomes are in a sense time varying covariates that I would like to include in a survival model for the time to Gleason risk classification. Of course, the first choice of how I could achieve that is by using the very well-known time varying Cox model. But the problem in using this model for this type of covariates is that the time varying Cox model is specifically designed to work with what is called exogenous time varying covariates. Whereas in our case, and because I measure these covariates on the patient himself, these are examples of endogenous time varying covariates. And it is known that if I have endogenous time varying covariates and I'm going to use my time varying Cox model, I may have bias in my estimated coefficients. So this is where indeed the framework of joint models for longitudinal and time to event data comes into play, because it's a framework that explicitly accounts for this endogeneity of these time varying covariates. Now, if you haven't seen a joint model before, so I would like to use this plot here, this GIF, to explain you very intuitively what a joint model is doing. What the joint model is doing is that on my x-axis, I have my follow-up time. So here I start from time 0, from time the patient enters the active surveillance program. And then during the follow-up, I measure a biomarker for this patient. So like in our case, I measure the prostate-specific antigen, this PSA. And what these models are doing is first that are estimating what you see here, this red line, okay? So they're estimating every new measurement that comes for a patient. I'm estimating how is this underlying trajectory of his PSA profile. And then I take this estimated biomarker trajectory and then I include this estimated biomarker trajectory in a survival model. And this is what we read here on the right-hand side, okay? So I get survival probabilities. So I link this estimated longitudinal trajectory to a survival model to give me a survival probability. So this is what is essentially a joint model. Okay, so that has been in a very simplistic case. So for our specific application, the joint model that we are considering is a little bit more complex. And then I'm going to show you here a little bit more information about it. So first of all, I will denote by TI with an asterisk the true risk classification time. And in our specific situation, I need to account that I actually have an interval censored setting, okay? So because in one biopsy, the Gleason would still be a 7, and then in the next biopsy, the Gleason will be, in one biopsy, the Gleason will still be a 6, and supposedly in the next biopsy, the Gleason becomes a 7. So therefore, this means that the Gleason really became a 7 somewhere in between these two biopsy times. So therefore, to account for this interval censored nature of our data, I introduced this TIL and TIR times, so to denote the times of the two biopsies between which the Gleason became a 7. And then I also, in my case, I don't have one biomarker, but I have two biomarkers. I have the PSA and the DRE measurements, where I said the PSA is continuous and the DRE is dichotomous. So therefore, the joint model that we have considered for our setting has the specification that you see on the slide here. So in the top equation is the hazard function for the Gleason time to Gleason 7. Okay, so this is the hazard function for our survival outcome. So when the Gleason will become a 7. So where I have the baseline hazard, here I have baseline covariates, and here I have my two longitudinal outcomes, which are included in this hazard model as time varying covariates, as you see here. And the first term refers to PSA, and for PSA I'm using, because it's a continuous time varying covariate, a continuous longitudinal outcome, I'm using here a mixed effects model to get this red line. Okay, so I'm using to get this red line, I'm using a mixed effects model, a linear mixed effects model. And then for the Gleason risk classification, for the DRE, because it's a dichotomous outcomes, I'm using a mixed effects logistic regression. Now, what is the key component in this specification of these models are these random effects. Okay, so these random effects are the terms in the specification of this model that they have a double role. So what is their double role? So first of all, they specify how this red line looks like per outcome. So why a particular patient has a more increasing PSA, whereas the other patient has a stable PSA. Okay, so this is what these random effects are doing, and this is are doing it here for PSA and here for DRE. But then these random effects are also included in the survival model. And because they're also included in the survival model is how the association is built between these outcomes. And let me stress here that these random effects are not observed. Okay, so these are latent variables, unobserved variables that relate these three outcomes. And this is the specification of the joint distribution. So in the joint model, I specify the joint distribution for my two longitudinal outcomes and my time to event. And as I mentioned, are these random effects that explain the interdependencies between these outcomes. Okay, just as additional points to make here, what this type of framework also allow us to do is to include also different specifications of our time varying covariate. And motivated by previous research in prostate cancer, and in particular for the PSA biomarker, what it has been shown is that it's not only the level of the PSA that is important, but what is also important is what is called the PSA velocity. So how fast PSA has been changing for a particular patient. And in our context, we can include this PSA velocity as the derivative of our mixed model with respect to time. Okay, so what is the derivative of the red line that we have seen before with respect to time? So that will give us what is the velocity. So just to show you here again with a graphic. So therefore, we say now that the hazard for the Gleason to become a 7 does not depend only on the value, on the level of the PSA, which is here this green line, but also depends on the slope, where the slope is this purple line, this magenta line that says what is the velocity of the PSA at a particular time point. Okay, so going back then to our three-step procedure. So we have seen with the previous model, we have seen how can I link the three outcomes, okay? So how can I link my longitudinal outcomes with my time to Gleason classification? So the next step that we wanted to perform is to see how can I use now these longitudinal outcomes to predict the risk of the Gleason becoming a 7, okay? So I know that currently the patient is still a 6, and I want to know what is the risk that this patient will have a 7 at some future time point. And from the definition of the joint model that I have shown you just a couple of slides earlier, so we can derive this risk, so which is a probability. And this risk has this specification that we see here. And I would like now to go a little bit to see what are the different ingredients in this formula. Okay, so first of all, if I take here the first term, so this is the term that tells me up to which time point I know that the patient had still a Gleason 6, so no progression has occurred here. Okay, so this time point T, I can use this figure here. Okay, so this is when the patient started surveillance. And now this time point T is like, so this year 1.5. So this is the time point when this patient did his last biopsy. And at this time point, I know that the Gleason was still a 6. Okay, so there was no progression yet. Okay, but Then I have these two extra terms. So these extra terms are my two longitudinal outcomes. Okay, so this is the PSA and the DRE. And I have measurements for these longitudinal outcomes up to time V, where the V is the current time, so when the patient is in front of the doctor. And then this V will be later than T, okay? So because, again, remember that when we don't do biopsies every time the patient goes to the doctor, okay? So we want to restrict how many biopsies we'll do, but the patient does go to the doctor for a PSA test, for a blood test, okay? So therefore, this is our current time. So this is the V. So we are now at year 2.5. The last time the patient did the biopsy was 1.5. And then we have this measurement that I have recorded. Okay, so all these are the PSA measurements. And now using this information that I have available up to my current time, so up to 2.5, I can calculate what is the risk of progression, which is this probability. And in the figure, this is this red line. Okay, so this, I know that at 1.5, the Gleason was still a 7. And then after 1.5, I can estimate what is the risk that this patient progressed. And this is given by this red line, as I mentioned, and the shaded red area is the 95% confidence interval. Okay, so I can calculate that from the joint model, so I'm not going to say you how exactly this is done for the sake of time. But we can calculate these probabilities. We can calculate this red line from our joint model, and then I can do that per patient, and I can do that every time I have a new measurement. So this is where the dynamic nature comes into play, that every time the patient comes again for a new measurement, I can recalculate this risk and get an update. But now comes our last question, okay? So therefore, I have calculated the risk. Now the question is, how do I decide if I will do a biopsy or not? Okay, so first of all, here what we denote is when does the doctor want to make this decision, okay? And we say here, in the context of our study, that the doctor wants to decide each time the patient comes for his PSA measurement, okay? So I have a new measurement for PSA, and using this new measurement, the doctor wants to decide, should we do a biopsy or should we wait? Okay, so therefore this S sequence, S1 to Sn, is a sequence of time points that the doctor would like to take the decision of whether to perform a biopsy or not. So these are the time points. So this is S1, our current visit, and these are the time points. So 3.5, 4.5, 5.5, and so on are the time points when the patient will come again, and the doctor would like to decide. Okay, so then how do we decide? So our suggestion is to do a very simple decision rule. Simple to say that we are going to decide to do a biopsy at a particular time point if this risk of progression, so this is the risk of progression, this probability exceeds a threshold, a kappa. Okay, so again, to give an example, let's say that I use a kappa of 12%. So to see, is currently I am here in 2.5, is the risk above 12%? So if it is above 12%, then the decision would be, yes, you should do a biopsy now. Or if this risk is below this threshold of 12%, then you should wait. And then you should come back again. And then I'm going to do the calculation again and decide at the next visit. Okay, so this is our very simple idea of how to personalize the biopsy schedule. Of course, now we have, in a sense, translated the question, okay? So the decision of how, when to do a biopsy has been translated on how to select this kappa, okay? Because, of course, above the value of kappa, I do the biopsy, and below the value of kappa, I'm supposed to wait. So therefore, now the relevant question becomes, how do we select the kappa? So we use 12%, we should use 20%, 10%, how we should do that? And should we be using the same kappa for all times? So should we use the kappa of 12% in the beginning of the follow-up, but also the same at the later of the follow-up, or late in the follow-up, we should use another kappa. Okay, and then, of course, here there can be different approaches to go about. So first of all, something that I will also mention later, we can go about in the context of what is called shared decision-making, and therefore the doctor, together with the patient, may decide of what is the risk that they are currently willing to take. So to say, okay, taking a risk of 10% seems appropriate, or the patient is willing to take this risk, and the doctor can explain what this will imply. But really to help them also to make also this translation and also help them decide, what we also consider in our work is to suggest the value of kappa that tries to balance the two relevant quantities that I have already introduced from the beginning of my talk. Okay, so remember that in this problem that we are trying to attack here, there are these two dimensions, the two relevant quantities. So is how many biopsies I'm going to do and what will be the delay in finding the cancer. And therefore, we said that if you're going to do more biopsies, the delay will be shorter. And if you're going to do fewer biopsies, then the delay could be possibly longer. Okay, so therefore, what we want to do is to translate this kappa into these quantities, into these dimensions. And this can also help in the discussion between the doctor and the patient. So to say that if you're going to take, for instance, if you are willing to take a risk of 10%, this means that you are going to do that many biopsies from now until you die in the future. And then if supposedly you will progress, then the delay in finding this progression will be that many months. Okay, so therefore, the physician together with the patient can come into discussion of what this risk really means practically. Okay, but this can also help us in the sense to try, and this is an approach that we have suggested, to try to optimize the balance between the two. And how we thought about optimizing the balance between the two is to think about what is the perfect scenario. Okay, so what is the perfect scenario is to do only one biopsy at exactly the time point that the Gleason becomes a 7. So if we knew that the Gleason becomes a 7 at 3.2 years, then we should plan the biopsy at exactly this time point and find it, okay, and don't do any unnecessary biopsies. So therefore, what we would try to think about is how can we approach this ideal situation, this ideal scenario. And how we could do that is, first of all, to realize indeed, as we mentioned, that every choice of kappa that we make, this translates to how many biopsies the patient will do and what will be the delay. So if I specify a threshold, which I call here kappa asterisk, so what we can do from our model is that we can calculate the expected number of biopsies. Okay, so we can calculate how many times we expect this patient to do biopsies in the future based on the risk of 12%. Okay, and so like here, we say that here you're not going to do a biopsy. Here at 3.5, you will do a biopsy. At 4.5, again, we will not do. At 5.5, you will do again. So therefore, in this follow-up, this patient will do 2 biopsies in the future. Okay, so given our current information, given our current knowledge, this is what we predict for this patient, that he's going to do in the future 2 biopsies. Okay, and mathematically, this is what is behind this formula. Okay, so I can see when the probability will be above this kappa asterisk, so above this 12%, and I'm going to count it. Okay, so how many times this probability was above this kappa asterisk. And that will give me the expected number of biopsies that I will do for that patient. And in a similar manner, what we could also calculate is what will be the expected delay. Okay, so if supposedly you use a threshold of 12%, you are going to do 2 biopsies in the future, and the expected delay. So if supposedly cancer really progressed for you, okay, so if this happens, so the delay in finding the cancer will be that many months, okay? So that will be here this expected delay. And so we have done this calculation for 12%, as I showed you in the example, but essentially we can do the calculations for many different values of kappa, okay? And if I do that for many different values of kappa, I take a figure like that, okay? So every point that you see here is a different value for kappa. And on the x-axis, I have how many biopsies the patient will do. And on the y-axis, I have what will be the delay, okay? And this is in years. And here, this is our ideal schedule, our ideal situation, because here is I do the biopsy at exactly the time point that the progression occurred. So here I do one biopsy and the delay is 0. So therefore, how we could select what will be an optimal value for kappa will be what is the value of kappa that has the shorter distance from this ideal schedule. So this is like the shortest Euclidean distance. So if I weigh the same, the number of biopsies and the expected delay, then the value of kappa that is closer to this ideal schedule is this 23%. Okay, so that has been one suggestion that we make. Of course, it could be that at different follow-up times, you weigh differently the expected biopsies and the expected delay. And therefore, if you weigh differently, you can come up with other optimal kappa values. Or again, as I mentioned earlier, the doctor together with the physicians could really translate what the different kappa value means. To say that if you are willing to take a risk of that much, this is how many biopsies you're going to do in the future, and that will be the expected delay. Okay, so as I said again, we can select the optimal kappa to specify clinically acceptable delay. So to say the patient, I don't want it to have a delay more than a year. So what will be the kappa value that satisfies that? And therefore, that will require that many biopsies. Okay, so that brings me to the end of my presentation. So I would like to give some considerations of the approach that we have proposed. So this approach for personalizing the scheduling of invasive procedures. So I have presented it from using this prostate cancer example, but the same approach can be used in many other settings. So where I have some invasive procedures that are given to the patients, and I would like in a more optimal and personalized way to schedule these procedures more effectively. Now, how a requirement in our approach is, of course, that you have a well-calibrated model, because you want these risk prediction, these probabilities that you get to be accurate probabilities. And the performance of this personalized approach will improve the better biomarkers you have, okay? So if you don't have a very good biomarker in really distinguishing between the risk of patients, so therefore there's not enough information in the data to try to personalize this scheduling procedure. But if you have longitudinal outcomes that really have good information in predicting your event, then this is where this approach will become more and more effective. So we have some papers which document this approach in biometrics, medical decision making, and statistics in medicine. These are also implemented functions to do that in the JMBase package. And for specifically for the prostate cancer example, we have also created a Shiny application that implements its approach. So you can go there and you will see, if you go to this URL, you will see a demo patient being analyzed, but the doctors can also import data of a particular patient and use this approach to calculate the expected number of biopsies, expected number of delays, and help them in their decision making. Yeah, so that brings me to the end. So I would like to thank you for your attention. And you may find the slides available in my GitHub page in the repository called Personalized Schedule. So if you go there, you can find the slides that I've shown you here. So I will be happy to take any questions at this point.